want to thank Cypress for the opportunity to come speak and sponsor Cypress University. Actually, I don't know if Tom has a different version of the story, but I met him the first time in Denver. Actually, I was in conversations with Drew, who a lot of you know is a rep at Cypress, and he said, yeah, you really got to meet Tom. You got to tell him about your idea with direct primary care. He's the guy over at the bar. So I go over to Tom, we have a good discussion, and just start engaging in this idea late 2017 about building a direct primary care network. So I'm going to give you a little bit of background in my presentation on what direct primary care is, its sole purpose, and then how we're disrupting the market and changing. But I'm not a big gambling person, but when I first got here, my wife said, you know, you're in Vegas, just go to the roulette table. It's a 50-50 shot, red or black, right? So I go to the roulette table, never really gambled before, don't really know the rules, don't really follow it, just a busy person. I'm really tired. I got in from a long flight. I took a flight from Fort Myers to Charlotte, then a 5-hour shot here to Vegas. So I'm just like, I'm tired. I sit down at the table, put 25 bucks on red, boom, it hits. Like, I know this is I'm gonna win now because I'm tired and I want to go to bed. So it gets up to about 200 bucks. I got red, 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 and then I chose black and hit black too. Put it in my pocket. I decided that I would spend my next night, which is last night, and just treat myself to a show. So, you know, one thing always leads to another, and I sit down at in this show. If you haven't seen Absinthe, it's the little tent that's just outside of Caesar's Palace. And, you know, took a little risk. Go in there, I take the second row seat, I sit down, the show begins, there's people spinning around. I won't spoil the show because it is a fantastic show. And the girl sitting next to me, she says, "You like Trump, don't you?" I'm like, "Really?" I said, I kind of view things bipartisan, but we get into this conversation. She's from Canada, and while the presentation's going, she's talking about healthcare in Canada and how Canadians like the Obamas and blah, blah, blah. And I'm like, look, I don't want to argue about politics and healthcare while we're trying to watch a show, but nonetheless, you can't ever escape what you try to do. So, you know, I didn't invent direct primary care. Direct primary care has been around for a really long time, almost a decade. But the reason why direct primary care is so important is because, as you all know, I mean, you're all very progressive, you're risk takers, or otherwise you wouldn't be here, right? A lot of you are middle market sized companies that have moved your company to self-funding. You've taken the risk. You've broken through the status quo of the fully insured world. In the healthcare world, the traditional healthcare system, as you know, is completely broken. And fee-for-service reimbursements are continuing to decline. Physicians feel like this. Doctors that I talk to, I have physicians that are in my CrossFit that tell me that they've got patient panels of 3,000, 4,000 patients, and they just have to fake it every day, right? They see patients for less than 12 minutes at a time, sometimes 5 minutes. Sometimes their leadership, if they work for a hospital, require them to see patients for less than 6 minutes, whatever it is. But they can't deliver quality care. And you all know this, that your employees are not getting the quality care they deserve because they do not have enough time with a doctor. 22% of a physician's time is stuck doing non-clinical work. Administrative stuff dealing with claims, authorizations, prescription refills, it's a huge mess. And the last point is that a lot of the doctors, they have very little family time. So a lot of MDs come out of school expecting to practice primary care and deliver quality medicine, and then they fall into this destructive fee-for-service system. So direct primary care, what its core mission is to restore the relationship between the patient and the doctor. Our doctors, when we go in to contract them, the practices we contract have to agree that the patients get at least 35 to 45 minutes apiece, fully going through their medication, other lifestyle indicators to make sure that they're not missing anything that they would in the actual conventional system that we have today. So going back to a little bit of the history on direct primary care, there were innovators and early adopters who were really the visionaries of direct primary care. And I speak to a lot of people around the country about this, and some have never heard of them, some have heard of them. But really, they were the very beginning, and they set the foundation. So some of you might be from Washington State. And if you are, you're very familiar with Q-Liance. Q-Liance actually started in 2012, and they peaked at 13,000 members. Their purpose really was truly to completely abandon the fee-for-service altogether. They didn't take any insurance. They just charge a subscription fee. It was like Netflix for healthcare. That's all. You pay the fee, and you get everything that you expect when you go. So they actually touted for the employers that they worked with that they were saving employers about 20% on their healthcare. But unfortunately, because of multiple things, the establishment, politics, legislation, they shut down. They were way ahead of their time. Ironically, here in Vegas, at the time, in 2012, there was a $250 million revitalization attempt of Vegas. And through that effort, they actually wanted to create a program, a direct primary care model that was fully integrated with insurance models. Again, it was ahead of its time. Dr. Damania, who's the picture sliding up there, he's actually famously known on YouTube. He does a lot of rap songs on, parodies of working in a hospital if you're a doctor there, and he's very instrumental in encouraging doctors to kind of get out of the normal fee-for-service racket. But they shut down too. They shut down because, why? They were way ahead of their time. So, as a little bit of a summary, where is direct primary care now? Direct primary care literally is in over 1,000 practices in 48 states. It's not going anywhere. It's not something that's a trend. There's a lot of things in the benefits industry that show up, they're like a bright, shiny object, everybody jumps on it, and then it's gone. This is completely revolutionizing healthcare the way that we know it. In fact, so much that the Centers for Medicare have instituted pilots with direct primary care doctors for Medicare and Medicaid. That's very important. Actually, there's legislative history, and many people don't know this, but actually in the Affordable Care Act law, Section 1301A3, you can look it up, it actually permits direct primary care centered medical home as allowable under federal law. Nobody knew it. 25 laws have had bipartisan legislation, both Republicans and Democrats, and we all know they don't agree on much. But the Direct Primary Care Coalition that's in DC, I participate in on their steering committee. There are approximately 51 physicians that participate in that committee and have done a great job to legislate and get things passed. So where we are today, there are 31 states that have actually passed direct primary care. Let me go back here, sorry. We'll get to that in a minute. So one of the other core fundamental pieces about direct primary care is the focus on these 8 risks and behaviors. You cannot tell me that seeing a primary care doctor in under 6 minutes can address those 8 risks and behaviors. It's almost impossible. In fact, there's such a high margin of error, this is a reason that contributes to a tremendous amount of chronic conditions that could be stopped if the patient has the adequate amount of time with their primary care doctor. What the CDC says is these 8 risks and behaviors that contribute to chronic conditions that lead to 84% of all healthcare spending, for which 50% of the population have one or more chronic condition. It's a big deal. And a lot of you that are self-funded, you might be scratching your head and going, primary care, all right, that's 2 to 5% of my spending. I got news for you. It affects 50% or more of your claims if you can stop things. So I had a keen interest in doing direct-to-provider because for my clients, started in 2005, 2006, I had a lot of fire districts. I didn't even know this was going on, and I was bringing doctors out to do physicals and doing on-site clinics for customers, and we had some zoos in our book of business, and we brought doctors out to do TB shots. So we were already doing direct-to-provider in advance of the movement starting. But as I've seen direct primary care grow, right, and practices all over the country, there's a tremendous amount of problems with it. If the direct primary care industry is going to work and translate into the employer-driven market, things have got to change. The direct primary care practices that are out there now, 95% of them focus on individuals. They don't focus on employers. They're not scalable. And if you're sitting here as an employer, and I know half the audience are employers, you have employees across multiple counties, could you visualize contracting with 7 different direct primary care doctors who all charge a different rate? The answer is no, it's not going to work. I've worked with employers for almost 20 years, as Tom said, between ADP, Paychecks, dealing with being a retail benefits broker for almost 14 years. We sold the agency last year. But what we found too is that a lot of these doctors don't want to work with brokers. A lot of the pure DPC doctors that don't take insurance at all, they blame brokers as also being part of the problem. And that's not good. So what we're trying to do is work with physicians and create more of a hybrid model where they still take fee-for-service and then they also take direct primary care patients. I should also say the last few points there. The other problem is physicians that try to do everything, right? I tell them, I'm like, you're the MD, I'm the MBA. I'll build the structure and the business process, you handle the clinical side. But doctors who I call it the superiority complex, there are DPC models out there that are physician-driven 100%. Not that that's bad, but they try to do it all. They want to take care of the patient. They want to go out to the client. They want to go sign up the customer. Now they're trying to learn self-funding. It's a mess. So affiliate practices are one other problem too that I believe is a big issue for the industry, because what they do is they say their brand is superior. They're like the floating head. And then they sign up another doctor, and then they charge you, the employer, a certain rate, and that doctor takes a cut of that doctor, which drives up the rates for direct primary care. That's not going to help things in the long run. So there's other things too with primary care, right? We have this commoditization of primary care happening across the entire country. CVS, right? They're investing $1 billion in CVS. Their stock, after the Aetna acquisition has dropped a little bit because they're rebuilding the infrastructure to put doctors or PAs in the CVSs with the concept of driving your employees to their clinics. Walgreens following suit. United Healthcare, their MedExpress they own. So they're trying to get to the customer. It's a race to who can get the customer from price, value, and convenience perspective. But direct primary care's role really is to create more of a quality approach versus a quantity and get them in, get them out type of approach for healthcare. And then, of course, the unusual competitor, which is Amazon, now Haven. And what is their role going to be in primary care in the future? It's probably going to be that you can go out to Amazon or ask Alexa, right? I need a primary care doctor, and she'll tell you who it is, and it gets on your Amazon subscription, and you can go to the doctor unlimited. That's where it's going. So now things are catching up legislatively, and that's a big plus for direct primary care, because as I told you with Q-Lines and Turntable, they shut down because they were ahead of their time. And now you can see that as of 2019, there are 31 states in the green that have legalized direct primary care. They allow physicians to create this payment model and offer it to both employers or individuals. Some states have gotten a little hung up, and the states that are starred, those are the states that have Medicare and Medicaid pilots. So you're seeing how this is sweeping across the nation in a very fast way. So a little bit of background on how I kind of created my model for direct primary care. It all started with a bet. I told you about my little bet on my first night when I got here. But I went to a doctor in Naples, Florida. His name Dr. Abood. Big clinic. He's a pro-patient kind of guy, super high quality. He has 2 locations, 11 board-certified ER doctors, with the goal of trying to not have somebody go to the hospital, take care of it the best they can in the urgent care setting and get them out. I said, what if I created a way to pay you like a subscription fee and make it reasonable, and I'll bring employer groups to you, because I've done this for 13, 14 years in Naples, and I'll bring you 16 groups. And we met like 4 times, and he was really skeptical. And it was in the very beginning of me starting Clinical Wellness Network. And we sat down for coffee, and he says, all right, I'll do it, but I'm not going to sign your contract. I'm like, Dr. Bood, can't do that. He says, we're going to make a deal. I said, all right. He said, if I pay out more in service fees than I collect from your model in subscription, then I'm going to bill you. I said, all right, that's a one-sided deal. That's not a good deal. So we're going to make the other side of it. The other side of it is, if you receive more than you pay out, you pay me the difference. So we shook on it, walked out of there, went to the 16 employers I'd trusted for a very long, long time, put those employers on board. I didn't get a call. November. Didn't get a call. December. So I called him the 3rd month. He goes, I knew the call was coming. Where do I write the check to? I said, no, you don't have to write me a check at all. I'm just wanting to prove the point that people are not going to overutilize something that's free, but they're going to use it when they need it. And economically, it's a fantastic thing because they're not paying egregious deductibles, out-of-pockets, co-insurances, surprise bills. There's no approvals. They just get health care the way it should be. So it worked. And Collier Urgent Care became our first 2-location provider, 11 doctors, and it was really awesome. And what I should say is our model does not charge the doctor. So if any of you are familiar with DPC and know DPC doctors, they're using platforms that have emerged into the country that are charging them 2% of gross revenues or charging them flat fees, or there's fancy EMR systems out there in the market that are charging them $250 a month or trying to charge them for telemedicine providers. We do all that, and we don't charge the doctor at all, with the intent of keeping the price per employee very low, which is what it should be. We create ID cards. Some markets we've actually bundled radiology. So we started doing direct contracts with radiology firms, doing things like $250 CTs, $350 MRIs, and steering people to these services. One clinic in Murray, Kentucky, that we have, Primary Care Medical Center, was so upset with the hospitals in Murray charging thousands of dollars for MRIs and CTs that they bundled MRIs and CTs in our direct primary care. So the employers in that community that we're talking to, the big plant there that we're in the process of with Briggs & Stratton, 660 employees, $3,300 average spend in MRI, they'll be able to get them for free, just paying for direct primary care for their employees and have the employees go to the clinic and get MRIs. So this thing's really growing. That was one of the, those are the main reasons why I started the direct care organization called Clinical Wellness Network, really with the purpose of leveling the playing field. And what we do is pretty simple. Number one, who's been so fantastic, Beth Bubb out of the Cypress Appleton office, she leads the charge. She's awesome. So our brokers that work with us or our team, when we submit employers, Cypress handles it all. In fact, Cypress built us a system to allow the physician to verify the patients, allow you as the employer to add and delete employees, also build a COBRA system. It allows the broker to access reports and does it all. Then we add the technology side of it. So if you're paying for telemedicine, great, but if you're participating in a direct primary care model like mine, you don't have to. It's all bundled in there. So we give your employees zero copay access to Amwell. They can telemedicine, they can connect with the doctor, and it's plug and play. We could pull that out and we can add the actual doctor to it, and we don't charge them. So then the primary care provider can just snap in and out of our model literally in 30 days. So I've had markets where a large employer says, we want to do something like this. So I go to the primary care group and I say, I have 500 employees that could potentially be your patients. And I push them down as far as I can on the direct primary care fee. Some of them as low as $40 a month. And then of course you have the broker. Our role is more of the program fiduciary. We're the manager of the program. We do the sales marketing. And it's been growing, which is a good thing. Getting more and more brokers to understand it. We do, my final first circle there I missed just before Cypress is, how do we also drive member engagement? Well, we put care management into the model. And that's bundled in our number as well. So we happen to use AIM, but if we've had other clients who have used other care management companies, we can just take AIM out and plug yours right in if you have one that you like. And I think there's some great ones that have presented so far that I've heard. So, walk around a little bit. So I was in Murray, Kentucky, negotiating with this primary care medical group, and my wife called me. She's like, yeah, we had somebody at the door. I said, really? Who? My house. So ring doorbell, fantastic. My daughter actually ended up answering the door, and it was federal agents from the Department of Labor, right? They'd received a huge packet about Clinical Wellness Network with all this egregious stuff that we're this like uncharted health plan and blah, blah, blah. Who do you think did that? Probably one of the bukas, right? So it's actually turned into a really great thing for us because it turns out that they weren't so much concerned about what I'm doing. What they were concerned about was how the employers deal with this thing called direct primary care. They want to know how should rates be standardized. So I ended up in some sense through this experience becoming more of a consultant to the Department of Labor and the Employee Benefit Security Administration. So I've traveled to Atlanta, I've had hearings there, I had discussions with the federal government in this sort of proxy, what I told them, free consulting role. And as a result, we have to do COBRA. They're defining us as a direct primary care medical plan, which is interesting. We fall under Title I of ERISA. So we have some other compliance things like we're building, we've just finished doing our direct primary care summary plan descriptions. We have to do uniform glossaries. It sounds like employee benefits, but we're really setting the stage, I think, for where direct primary care is going from a regulation standpoint. The last point on that is they've continued to ask me about, when I said to them in the initial discussions, I said, so do I have to tell you like the foundation of direct primary care? After all, you're the federal government, you should know what it is. We don't know what it is. We need to know from scratch. That's scary. So I had to end up sort of educating the Department of Labor on what direct primary care is. And the noise that we made ended up going all the way to Alex Azar as a Secretary of Department of Labor and making some waves in Washington to sort of continue to pave the way for the Primary Care Enhancement Act, which was passed by the House. And if you haven't followed it, what it does is it changes legislation so that your employees or you as an employer can co-sponsor direct primary care, have your employees on it, and have them in an HSA plan where they're making a pre-tax contribution. Under the current regulations, you can have a high deductible health plan. It's just your employees can't put pre-tax money in and be in a direct primary care plan. But that's going to change the game very big. So we're essentially creating a standard. It's a non-insurance monthly subscription program. We're creating a network of providers. We're looking for really good advisors that get it. I can't tell you how many brokers have contacted me. I've put them in place. They've used this as an innovation to write a group. They get the group, and they don't do direct primary care. Because what they're really ultimately after is writing fully insured, because that's all they know. So we're really trying to find advisors that get it and find employers that understand it. Typically, the cost of the direct primary care for the employee will end up being about $13 to $16 an hour per week. It's a lot less expensive than traditional health insurance, but it's a mindset change for the employee. Okay, go from that $1,500 rich deductible, go to a $6,000 or $7,000, use that for catastrophic, and use the direct primary care for all of your day-to-day. Yes, I know for the HR people that are in the audience that not everybody's going to want to go to the direct primary care doctor. From what we've seen, state to state, group to group, it's 75 to 80%. That same statistic are people in your group that are not getting physicals, that don't even have a primary care doctor. They will make the change. So, what's the experience look like for the member? There's a technology app that we built with Strive. We build in a digitized ID card process for the member, makes it really clean and easy. We also send them plastic ID cards, which is great too. So I'm going to jump through a few things because I want to get to, where is direct primary care from the standpoint of already working with large self-funded employers. Here's a few examples. Boeing has instituted direct primary care. They're huge, 14 states. The state of New Jersey, 800,000 employees, instituted direct primary care. 7,000 employees voluntarily signed up for direct primary care because they can get better access to the doctor. That's huge. That's massive. So how do you justify the investment in DPC, right? Are the savings real? What is this? I get all kinds of skeptics. I do a lot on LinkedIn. If you haven't connected to me, please do, because you can see studies and legitimized stuff. And I like to put stuff on things like #skeptics, because when you're doing something that's disruptive, 90% of the people you talk to are like, oh, it's never going to work. So we've recently created a really great relationship with KPI Ninja. And if you're not familiar with who they are, essentially what they do is they're physicians that have decided to put together a cost justification, which the CFOs in them really like. When you look at certain types of services that would ordinarily go through a regular primary care practice, what happens when you evacuate those claims, and what does that potential savings look like? This is just an example of a 268 life auto dealership that we had just given an advisor that's in Orlando. The dealerships are located in Doral and also in Miami. And we contracted a primary care physician within 2 miles of the dealership right after they had interest in this. And this is what we came up with. Worst case scenario, they're going to save $35,000. Best case scenario, $210,000. That's after the DPC plan costs. Not to mention the economic benefit to the employee, because they're not, with 85% of people that are paycheck to paycheck, and I know I'm preaching to the choir, you all know this, right? That paycheck to paycheck percentage is getting higher every year. 82, 85. People are seriously financially stressed. But not being able to pay anything to go to the doctor is a great thing economically for your lowest paid staff. Essentially, we're just evacuating claims. I got clients that are fully insured, we put this on top of. We have clients that are level funded, we put it on top of, and then the self-funded. There's some studies that have been done. If anybody would like them, connect me on LinkedIn, I'll send the studies to you. But Boeing, for instance, their location in Seattle, Saw a reduction in hospital admits based on the two populations of employees, those that had direct primary care and those that didn't. A reduction in 28% of hospitalization, 14% reduction in ER visits, because the doctors that are in that network are doing a great job to keep them out of the ER, with about a 20% reduction in total spending. So Q-Liance was actually right when they did it in the early days. BUCA, everybody's talking about BUCA. The last couple slides here deal with, what is BUCA's perception of this? Well, if you talk to a pure DPC doctor in any state in the whole country who's completely dismantled their fee-for-service contracts and are only doing direct primary care, they'll tell you carriers are bad, brokers are bad, and they speak about that all over the country. The truth is, I've spent the time talking to Aetna, Blue Cross, United, Cigna, Humana, and they're actually giving our groups in Florida, and I think we're going to start seeing this in other states, a discount on fully insured to sort of move out of the way. That's what we need them to do. They're actually saving money on their fully insured contract when companies are using and investing their dollars in direct primary care, because those are claims they don't pay. So even though these fully insured contracts are filed at the state, we're getting 5, 8, 10% on some cases that we're writing. And of course, some in the large group market, 51 plus fully insured, it really depends, but we're seeing like a 5 to 8% discount on those premiums. Self-funding, you need to have a DPC component that's integrated. There are some advisors in the room that I've already talked to that are already doing this. I know like Justin Holmes Murphy does a fantastic job in the Nebraska market integrating Strata. But we're seeing some cases that are getting 10 to 35% off their stop-loss premiums. You're evacuating all of those high-frequency, low-dollar claims off of your plan. And you may even be able to include some of your high-cost claims that you're currently paying. And you won't have to pay for them at all. Depends on the capability of the provider, right? But if we negotiate procedures, testing, minor surgeries bundled into that DPC payment, there's no more claims. So we also can integrate with TPAs. Obviously, Cypress is doing a great job. And a 10% off, a recent proposal we did off claims factors and working rates was almost a 65% credit versus the DPC. So the net for the employer after they got the credit off their stop loss in a self-funded arrangement was like $14 or $15 per employee per month. That's 100% worth the investment all day long.